Okay, welcome back. We're going to get on some junctional rhythms today where we left off. So last time we talked, we had talked about a couple different types of rhythms and where they originated. We looked at sinus rhythms that originated in the SA node. We also looked at atrial rhythms that were originating somewhere within the atrium that they weren't supposed to. Okay. So moving on, kind of moving downwards, right? That's the general trend here. We're looking at sinus rhythms and then atrial rhythms, and then we're looking at junctional rhythms, and same kind of concept. Like, why do we call them junctional rhythms? Because the electrical impulse that initiates the cardiac cycle, because remember, a cardiac cycle is supposed to be, at least in normal circumstances, a P, Q, or S, and a T. A normal cardiac cycle is a normal cardiac heartbeat, okay? So we call it a junctional rhythm because the electrical impulse that kickstarts that whole process, in this case, originates in the junction. This is obviously not supposed to be this way, so something's not working right if this is happening, but at least it'll keep you alive if things are not working properly. So let's talk about the different types of junctional rhythms. They're basically all kind of sort of the same thing, so they're just what we call rate dependent, right? So let's go to the whiteboard here, and let's just kind of draw something out and follow along. Let's see what we got here. So got a P, a QRS, a T, a P, a QRS, T, so on and so forth, right? But what if I was to draw something like this? Okay, what's the first thing that comes to mind that you're looking at? You're like, well, wait a minute, there should be a P wave right here, right? So in this bottom little rhythm here, we would say that our P waves are absent, okay? So what if we drew one like this? Well, what would we say here? So a P wave should look like that and lead to, but for whatever reason, it looks like that in this particular case. So this and that are what, well, they're upside down, right? The proper terminology is to say they're inverted, okay? So we would say we have inverted P waves, all right? So then there's one more kind of like rare occurrence that can happen, is that you can have something that looks like this, right? Something along those lines, or something along those lines. So that is actually a P wave. And I know you're sitting here like, okay, well, P waves are supposed to come before the QRS. Well, yeah, you're right. They are supposed to. But in medicine and in EKGs, there's like always that one exception to every rule. And it's a pain in the butt, I realize, but you just got to kind of go with them and learn the exception. So what have we looked at? We just looked at something that looked like that. We looked at something that looked like that. We looked at something that looked like that. That's very small inverted P wave. That is a inverted P wave, and that's an absent P wave, okay? So the criteria for junctional rhythms are basically absent or inverted P waves, okay? And it should have a narrow QRS complex, all right? And it should be a regular R to R rhythm. So a junctional rhythm should be narrow, regular, and have absent or inverted P waves. And it might have what we call them retrograde P waves, which could be after the QRS, okay? So the rest of it all is, it just matters on the rate, okay? So if you have a guy that looks like this, right? And we said, well, this is a rate of 50 for sake of argument. So that would be a junctional rhythm, right? But what if we had a guy that was the same exact thing? Oops. And these are your T waves right here, just so we're clear on things, okay? So this has absent P waves again. So there's no P wave here, 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 so on and so forth. So it's the same thing as the rhythm above. What do we notice though? The R to R intervals are closer together, which means it's faster, okay? So if this was a rate of 80, for example, we would say it's an accelerated junctional rhythm. And if you drew one out that was really, really fast, it was over 100, we'd say that's junctional tachycardia. So it just matters on the rate, right? Because 40, let me see here, clear all this out. Got too much going on here. So it just matters on the rate, right? So anything above 100 is going to be called junctional tachycardia. Anything from 60 to 100 is going to be called accelerated junctional, and anything below that is going to be called just a junctional rhythm. Okay, so here, let me go to the PowerPoint real quick. Oops. So let's just look at it on an actual computer generated strip. So junctional rhythm, right? So let me get the marker going here, annotate. So what do we notice here? So let's apply our rules that we should learn, because remember, we always want to have a systematic approach. So first question I ask myself is there P waves? Well, I would say there are no P waves. So all my other P wave questions kind of go out the window at that point. All right. Next question is, what are my QRSs looking like? Are they wide or are they narrow? Well, these guys look narrow because they're less than 0.12. And next thing I'm going to say is, well, what is my R to R? R to R looks regular to me. Okay. So what do we have? We have absent P waves, narrow QRS, regular R to R. And now I just got to kind of figure out the rate, because it has all the hallmarks and the criteria of a junctional rhythm, and that has absent P waves. Okay. It's just, we got to look at the rate. Okay. So let's actually calculate the rate here, just out of curiosity, and see what we got. So 5, 10, 15, 20, 25, 30. So this particular rate is going to be 50. Okay. So that falls in our junctional rhythm criteria. Had the rate been above 60 and been pretty much the same exact thing, we would call it a accelerated junctional. Like that. There we go, clear the screen. Okay, so pretty much kind of same thing going on here. Let's look at what we got, right? First question, do we have any P waves? Yes, we do. All right. Do I have a P for every QRS? Yes, I do. My P waves have the same morphology? Yes, they do. Are my PR intervals within normal limits? In other words, are they prolonged or not? They are not prolonged. Is my QRS narrow or wide? It is narrow. And my R to R interval is regular. So the only kind of abnormality with all of this is, while I do have P waves, they're not upright. They are inverted P waves. And our criteria for a junctional rhythm is here again. So in this particular case, we have all the criteria for a junctional rhythm, except the rate on this one is a little bit different. So let's just figure out what the rate is, just to be just out of curiosity, right? So 5, 10, 15, 18, and 20 small boxes in between each R wave, basically. Okay, so that would give me a rate of 75. If you're curious as to what I'm doing, I'm just doing it the precise way. So we talked about this previously, but just in case you're confused, if I want to figure out the exact rate, I take how many small boxes between two R's in a regular rhythm. If it's irregular, that goes out the window, okay? But I count how many small boxes are in between two R waves. In this particular case, I counted 20. And I'm dividing 1,500 by 20 or 20 into 1500, and it gives me 75. So it's an exact rate of 75. So I just, want to be precise. That's all. So what do we have? We have inverted P waves, narrow QRS, regular R to R, have all of the criteria for a junctional rhythm, except it can't be junctional because the rate is not less than 60. It has to be accelerated junctional because the rate is 75. Anything from 60 to 100 with all the junctional criteria is going to be called an accelerated junctional rhythm, okay? And once again, following the same theme for junctional tachycardia, let's look at what we got. So I'm looking here, and do I, once again, following the systematic approach, do I see any P waves? No, I don't. Just remember these guys. Hold on one sec here. Cool. These guys, I can make little arrows now. These are not P waves. These are T waves, okay? Just in case you're getting confused and just so we're all on the same page, these are T waves. Oh, that was awesome. Can do arrows now. I'm excited. All right, so let's see what we got. All right, those are not T waves. Or I'm sorry, those are not P waves. Those are T waves. So let's keep that in mind. So do I have P waves? No, I do not. So all my P wave questions kind of go out the window. Okay. You could also make the argument that you might actually have an inverted P wave right here. And that inverted P wave, retrograde P wave that comes after the QRS goes into the T wave, okay? You could make that argument too. But either way, whether you have absent P waves here or inverted retrograde P waves here, whichever, even if you were to make one argument or the other argument, it's still going to end up fitting the criteria for a junctional rhythm, okay? So no P waves, okay? Or maybe even possibly retrograde inverted P waves. What do we have for a QRS width? It's narrow, 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 narrow. We have a regular R to R interval. And let's just figure out the rate because we have all the criteria now for a junctional rhythm. We just got to figure out what the rate is. All right, so I'm going to do 5 boxes, 10 boxes, 11 boxes, and add one here. So 12 boxes. So 1500 divided by 12. That gives me a rate of 125. I promise that is a 5. And so anything over 100 that meets all the junctional criteria, we're going to call it junctional tachycardia. Okay. So junctional rhythms, guys, once again, pretty much same criteria. They need to have narrow QRS, regular R to R interval, and absent or inverted P waves or retrograde P waves. And if it's under 60, it's a junctional rhythm. If it's 60 to 100, it's accelerated junctional rhythm. If it's over 100, it is junctional tachycardia. Okay, very good. All right, so let's move on from junctional rhythms. And just as a brief refresher, why did we call them junctional rhythms? Because the electrical impulse that kick-started this heartbeat came from the junction, okay? Now let's talk about ventricular rhythms, okay? So why do you think we call them ventricular rhythms? Because the electrical impulse that kick-started this particular rhythm or heartbeat originated in the ventricles, or to be more specific, below the AV node, okay, or the bundle of Hess. So why would this occur? Like, why do we have a ventricular rhythm? Okay, there's obviously some sort of profound damage or maybe drug-induced effect, or there's something going on where the electrical conduction system of the heart is not working properly in normal working conditions, okay? So it's kind of going back to that whole like starting quarterback, backup quarterback, third string quarterback thing, right? So the starting quarterback, SA node, okay, for whatever reason, in this particular case, not working. So what do we got to do? Go to the backup quarterback, AV junction, AV node, not working. All right, what do we got to do now? Go to the third string quarterback. the ventricles, okay? So here's what I will tell you guys, just to kind of something to keep in mind, little tidbits of information that will help you, okay? If you have what we call a ventricular rhythm, okay, the ventricles are reliable as far as regularity, generally speaking, okay? So ventricular rhythms, without any what we call ectopy or ectopic beats, they should always be a regular rhythm, okay? But the hallmark of an electrical impulse that is originated in the ventricles is it's going to create a wide QRS, so greater than 0.12 seconds, okay? Now, not all QRSs that are wide means that it's a ventricular rhythm, okay? Later on, we're going to get into something called bundle branch blocks, okay? And basically what's happening is that you could have a sinus rhythm and everything is kind of normal looking, except for you have a wide QRS, because somewhere the electricity is getting blocked in one of the bundles, be it the left or the right or their subgroup fascicles. So not all things that are wide are ventricular rhythms. That's the takeaway, okay? But if it's a ventricular rhythm, it's going to be wide, okay? All right, so let's just kind of go to the whiteboard here. Actually, hold on one second. So as you can see, this is an idioventricular rhythm, really wide, okay? Really wide. So sometimes, guys, you can have positive or negative deflection, just depends on what's going on. You can have a ventricular rhythm that goes downwards, or you can have a ventricular rhythm that goes upwards, okay? It just depends. Because you can have VTAC that has like downward morphology, or VTAC that has more of an upward morphology, positive, negative deflection. It all just matters where the electricity is originating, which direction it's going. But let's not worry about that too much. It's just, let's identify things for right now. So if we had a rhythm that kind of looked like this, okay, and you're looking at it, you're like, what the heck is going on here? It looks weird at first, right? But let's just figure out what's going on. You don't always have an exact Q, R, and an S, for example, because R waves have to go up. And if it doesn't go up, you don't really have an R. You have just a QS, okay? But don't get hung up in all that. Let's just look at what we got. So first question, do I have P waves? No, I do not have P waves. So hallmark of ventricular rhythm is you're not going to have P waves, okay? There's no P waves. So this is just a little thing to throw in your head for later. It doesn't matter right now. But how would you tell the difference between a ventricular rhythm and a bundle branch block? One has P waves, one doesn't, okay? So no P waves, so that means all my other P wave questions can go out the window. So then I look at my QRS, all right? And let's just, for the sake of argument, say this QRS was 0.18, 0.18, okay? So that would mean we have a wide QRS. So remember when I talked about those QRS widths? One of the things that I'm just concerned with is this a wide or a narrow QRS? Because that tells me things. If it's a wide QRS, that tells me there's a possibility this could be a ventricular rhythm if I do not have P waves, okay? So in this case, we don't have P waves. We have wide QRS. And I didn't do a very good job of drawing it here, but you will always have a regular R to R interval in a ventricular rhythm. And then that's pretty much the criteria for idioventricular, accelerated idioventricular, ventricular tachycardia, wide QRS, regular R to R, no P waves. And then it's just rate dependent. So it's similar to the way the junctional rhythms were, right? So if you got one that is we're going to pretend that that's a regular R to R because I ran out of room. Let's say we have a rate of 20, and then you have one that's like this. Let's say that's a rate of 60. And then let's say you got one that's like, let's say that's a rate of 120. Okay, it's all pretty much the same thing going on. So in the top one, you have idioventricular rhythm. In the middle one, you have what we call an accelerated idioventricular rhythm. And then the bottom, you would have what we call ventricular tachycardia, because anything over 100, we're generally going to apply the term tachycardia to. So let's just look at our little PowerPoint here, what we got going on. Computer generated rhythm. You guys got to get used to looking at and what we call through artifact. So that you're going to see, and it's just, there's nothing other than this just comes with practice and training your eye. But this whole wandering baseline thing here is just artifact. This, whatever's going on here is just artifact, okay? This is not a very clear tracing. And honestly, when you show me a strip that literally has 2 beats on it, it's kind of like, can I get a little bit more here to go off of? Because I would like to know what's going on with that. Is this occurring every single time? Or was it just occurring at this particular moment in time, right? If it was just occurring at that particular moment in time, that one time, then it's probably not a P wave. Because you, generally speaking, either have P waves or you don't have P waves, okay? Because I could definitely see somebody saying like, oh, that looks like an inverted P wave to me. Yeah, I could see that. But if you have an inverted P wave here, you're going to have the same thing going over here. You're going to have it over here and over here. And as this strip continues to play out. So that's one thing you can do to kind of differentiate between what is artifact and what is actually legitimately happening. So in this particular case, what do we got? No P waves. That's artifact. No P waves. Wide QRS. Wide QRS. I don't know. What is it? Let's look. 1, 2, 3, 4, 5, 6 small boxes, maybe something like that. So from there to there, maybe around 6 small boxes, roughly speaking. So that's like 0.24 seconds. That's like double what it's supposed to be. So very, very exaggerated. And regular R to R interval, you can't really tell because there's only 2 beats. But if you played this strip out for a greater length of time, you would see that it is going to be regular. Okay, so that's the thing with idioventricular rhythms and ventricular rhythms. It's always going to be wide QRS, no P wave, regular R to R, and then what's the rate? Okay, if it's under 40, idioventricular rhythm. If it's 40 to 100, accelerated idioventricular rhythm. If it's over 100, ventricular tachycardia. Now, VTAC gets a little bit more tricky because there's different morphologies, and there's what we call monomorphic and polymorphic VTAC, and we're going to talk about that in a second. So let's just look at what we got here. This one's a little bit cleaner than the last one. So first question, do I have P waves? No, I do not. If you're curious as to what's going on, let's just label some stuff. This is your QRS right here, okay? And this is actually an inverted T wave. So your T waves can be inverted as well. It is common to see inverted T waves in myocardial ischemia when it's an acute finding. However, if it's something that they live with, you can see inverted T waves on premature ventricular contractions, and a lot of times on ventricular rhythms. A lot of times ventricular rhythms like this, they're just going to have inverted T waves because that's just how things look. So you're just going to have to get used to seeing what's normally correlates with another finding. So this is your QRS, inverted T wave, no P wave, in QRS, inverted T wave, QRS, inverted T wave, no P waves though, okay? So our P waves are conspicuously absent. So I have a wide QRS. So that would be, I got to look really closely, 1, 2, 3, 3.5 boxes. It's just a little bit over 0.12, right? It's hard to see on the screen. 3, oh, it's like 4 boxes, sorry. So if it's 4 boxes, we're looking at, geez, what is that? 0.16 seconds, okay? So that would be wide. So no P waves, wide QRS, regular R to R. That pretty much means it's a ventricular rhythm. And then it just matters what the rate is, okay? Just matters what the rate is. If it's from 60 to 100, we're going to call it accelerated idioventricular. So let's just out of curiosity see what we got. 5, 10, 15, 18 boxes. So that's going to be a rate of 83. So what does it mean? It meets the criteria for an accelerated idioventricular rhythm. Okay, VTAC. So this looks a little bit weird. And you might be like, well, is this thing upside down or is it right side up? Okay, so we're going to look at what we got here. So this is a downward wave. Okay, so this is not like the top of it, so to speak. This is the top of the wave. Okay, so you have a bunch of waves that are going down, 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 and then connecting. As if you're confused at what's going on here. Okay, so it looks a little weird the first time you see it. Okay, because it all just runs together and it's running really fast. But this is what VTAC looks like. I always tell you, don't memorize what rhythms look like, but you have to become familiar with what they look like to a certain degree. So familiarize with ventricular tachycardia because it has different presentations and different morphologies. The big thing to look at is that we don't have any P waves here, okay? We just have basically a Q and an S. Remember, an R wave goes upwards. We don't have upwards waves from the baseline here. So that's fine, that doesn't matter. But we have a whole bunch of QSs, okay? So, and you can just, a lot of people just say a QRS, even though it technically doesn't have an R. That's fine. No worried about that. The big thing I'm worried about is we need to identify this, okay? So no P waves, right? So all the P wave questions go out the window. What's my width? Is it narrow or wide? Okay, well, that's wide. QRS is definitely wide, and it's definitely regular R to R, even though we technically don't have R's. Well, you know what? I'm counting these wrong. My bad. You should be going like this. So, no P waves, wide QRS, regular R to R, okay? Regular rhythm, to be more specific. And then we just got to look at the rate, right? So 7 boxes, it looks like, something like that. 7 or 8 maybe. So somewhere between 187 and 214. So it's fast, okay? Big thing is it's over 100. So it has all of the hallmarks of a ventricular rhythm in that it has no P waves. It has a regular rhythm. It has a wide QRS. And in this particular case, the rate is over 100. And because the rate is over 100, we would call it ventricular tachycardia, okay? All right, so 2 different types of ventricular tachycardia. Now, you can have more than one shape on this type of VTAC. This is called monomorphic VTAC, okay? And they call it monomorphic because if you look at every one of these complexes, they all look alike. So mono being one type, one shape. Now they can look different and have different shapes than this particular strip shows you, but whatever shape one of them has, all of them is gonna have. So if it has a different shape than this, it'll still all look alike in whatever that shape is, all right? Now, if you have a VTAC that has multiple types of shapes going on at one time, we are going to call that polymorphic, poly meaning multiple, right? Polymorphic ventricular tachycardia. Now, they're going to call this torsade, another name that you'll really never hear somebody say polymorphic VTAC. It's very rarely used. People are pretty much always going to call this torsades. The full name's torsades de pointes, but everyone's just going to say torsades, okay? So what's happening here is that you're getting a twisting of the electrical impulses coming through the ventricles, okay? And by twisting these electrical impulses, you're going to get like different shape positive and then different shape negative deflections going kind of back and forth sometimes. And it can look a little bit different of the way, but at the end of the day, we still need to identify that this is VTAC. but it just has more than one shape. So it's going to be torsades, polymorphic VTach. All right. It's important to identify and differentiate polymorphic VTach from monomorphic VTach because they're going to have different treatments. One of the more common causes of polymorphic VTach torsades is going to be hypomagnesemia, among some other things too. But generally speaking, whereas the other one is just going to get an antiarrhythmic right away, like as in a potassium channel blocker, like amiodarone, or maybe like a lidocaine or a procainamide or whatever. That would be more right out the first line treatment for monomorphic VTach. First line treatment for torsades is generally going to be magnesium sulfate. Okay, so like why do we care? Because our treatments differ for these different things. So that's why we need to recognize it. So here's the thing about torsades. Okay, sometimes people can confuse it with ventricular fibrillation, a very, very coarse ventricular fibrillation. And we're going to look at Vfib next after this. But don't do that, okay? Because a person with Vfib is not perfusing, okay? It's going to be not a perfusing rhythm, as in like they don't have a heartbeat. They're basically in cardiac arrest. Your VTachs, either or, monomorphic or polymorphic, they can present with a pulse or without a pulse. So you got to be a little careful. But I don't want to get off track for right now. That's a whole nother conversation. But it's just important. What I'm trying to emphasize here is it's important to accurately identify things because your treatment algorithms kind of become a fork in the road sometimes between one thing and another. So what do we got here? So no P waves, right? QRSs are wide. It's kind of sort of irregular, so that gives us a idea that ventricular rhythms should be regular. So if it's irregular, like there's something weird going on. And then you look at kind of like the different morphologies. So you have like positive deflection. Oh, hold on, let me get sorry, I thought my pen was already. So you kind of like look at this guy and this guy and this guy and this guy. And you have like positive deflections, and you look at this guy with like a negative deflection, and then you come over here and then you got some more positive ones and then a negative one, right? So we're going like just, positive to negative deflections where that's the electricity that's twisting through the ventricles is basically what you're seeing. So the big thing is just be able to identify and differentiate torsades versus monomorphic tachycardia. In my opinion, let me clear the screen. They're pretty easy to tell apart and to oversimplify it because one of them looks exactly like all of the other and the other does not look exactly like all of the other. Okay. All right. So that pretty much wraps it up for 8 sinus rhythms, atrial rhythms, junctional rhythms, ventricular rhythms. Okay. One of the things you're going to see with a lot of the rhythms is what? It's just rate dependent. All right. So things that we still need to cover are going to be blocks, which are kind of technically rhythms unto themselves. They're just a little weird. So we're going to talk about them. And we'll also talk about some other things like Vfib and things like that. And we're going to use this video to finish up our rhythms. And then we're going to use another video to talk about things that happen to rhythms. So if you're going along in the PowerPoint, you're going to see that I kind of moved around a little bit. So if you were looking at things like premature atrial contractions, premature junctional contractions, premature ventricular contractions, sinus arrests, all that stuff, those are things that happen to rhythms, okay? They're not rhythms themselves, really. So we're going to talk about that in the next video. So let's just keep going for what we got to do now. Let's talk about Vfib real quick, and that'll pretty much end it. So Vfib is not a perfusing rhythm, so it does not produce a pulse. So it's important because that means this person's in cardiac arrest. Now, Vfib is Vfib, but there's kind of different types of Vfib, so to speak. And there's what we call coarse Vfib, and then there's more of a fine Vfib, okay? So, and it can look even more coarse than this. But if you're looking here, you'll notice that this circle versus this circle, your you have kind of just a bunch of chaos going on right here. But you'll notice that there's more amplitude on this one than there is this one, okay? And that's the hallmark difference of coarse Vfib versus fine Vfib. Is quite simply you have whatever waves, even though they're not true waves, they're just fibrillating waves, whatever waves are being produced, coarse Vfib is going to have more amplitude towards them, okay? So sometimes people with a really, really coarse Vfib, which this is not, I mean, this is coarse, but it's not like really coarse. Sometimes people will confuse a very, very, very coarse Vfib with the torsades, okay? And I can kind of sort of understand that and see that a little bit. The best way you're going to be able to differentiate the two of these things, just off of the EKG itself, is that coarse Vfib is going to be much, much more chaotic, and there's going to be no discernible pattern or similarity between really any of these waves. It's just a bunch of craziness, okay? Whereas polymorphic ventricular tachycardia torsades is going to be it's going to look different, but it's going to be much more organized looking than a coarse Vfib, okay? And at the end of the day, what's the difference between coarse Vfib and fine Vfib clinically? Like, why do we care? It just has to do with a term that we use in cardiac arrest called salvageability. And I know that term, if you've never heard it before, might seem morbid or kind of like heartless or whatever, but it's just being realistic, right? If you have a person that is in asystole, which is a flat line and has no electrical activity, they're going to be most likely, on most circumstances, harder to bring back than a person who's in Vfib. Because a person in Vfib, while the heart is not pumping, mechanically speaking, it's still at least producing electricity, even though that electricity is not organized. So a person in asystole, their heart's not doing anything mechanically, it's not doing anything electrically. So that's going to be much more worse prognosis typically. So if you ask me, I would say that coarse Vfib, neither of these are good, but coarse Vfib is probably a little bit more manageable than fine Vfib, okay? Just because the heart still has enough energy, and whether it's aerobic or anaerobic respiration at this point, I don't know, but it's still got enough juice left to produce a little bit more electricity. So that's Vfib. So just kind of, let's see here, just kind of recapping some things. Vfib is never going to have a pulse, okay? So if you see Vfib, you need to start CPR. VTach is kind of a weird rhythm in that it can present with or without a pulse. So you just need to check, okay? Especially if the person's unconscious. You need to check if they have a pulse. All right, and then I don't want to get into all of the rhythms that do and don't have pulses. Just remember, guys, an EKG is simply an EKG, and you always have to treat your patient, okay? There's this old saying, right? And they say, well, treat the patient, not the monitor. Well, I say treat both, okay? Look at what the monitor tells you, look at what your physical exam and your hands-on stuff on the patient tell you, and put all those things together and make a good decision on what you need to do, all right? All right, so let's talk about blocks. Let's talk about blocks. Let me find the blocks on here. So they have all these, like, there's a lot of different, like, memory aids and mnemonics and all kinds of things floating around out there for the heart blocks. If you like that kind of stuff, by all means, do whatever you do to help you remember it. Personally, like, I hate stuff like that because it just feels like one more thing to remember for me. So if you like that, then by all means do it. There's like this poem. There's something that somebody, I'm sure you'll hear once upon it or some point in your life about a second degree block, type 1, a second degree type 2, and a third degree, and things start getting farther and farther apart from one another. And somebody's going to give you this crazy story about like a family that gets divorced and all this stuff. Like, it's crazy. Like, that's what I learned in school. I remember just sitting there like, you guys are talking about divorces, and I thought we were doing EKGs. Now I'm very confused. So I'm not going to tell you any of that stuff. I'm just going to tell you what you need to know. And if you like one of them things and you find it on the internet or somebody tells you, then by all means, go for it. All right. So first thing is going to be, let's just talk about what the blocks are. So we got a first degree AV block, a second degree type 1, aka Mobitz 1, aka Winky block, a second degree type 2, aka Mobitz 2, and a third degree block, aka complete heart block. Okay, I know. Why can't we just have one name for things? I get it, right? But that's just how it goes. So here's what I'm going to tell you. A first degree AV block is not technically a rhythm unto itself. So if you handed me a strip and I looked at it and I go, and then you say, what's wrong with this patient? Or what rhythm are they in? I say, oh, it's a first, they're in a first degree block. Well, they're in this particular case, sinus rhythm. They just have something happening to their sinus rhythm, and that it is a first degree AV block. So a first degree AV block, guys, is very, 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 very simple. The only criteria for a first degree block is going to be a PR interval of greater than 0.20 seconds. That's it. That's all. Okay, so remember how we talked about a normal PR interval should be 0.12 to 0.20 seconds? Well, why does that matter? Because anything greater than a 0.20 second PR interval is going to be considered a prolonged PR interval, and that is going to be considered a first degree AV block. Okay, this can be caused by electrical conduction abnormalities in the heart. It can also be drug induced in the heart. Okay, so what do we got? Let's apply the systematic approach. Do I have P waves? P wave, P wave, P wave, QRS, 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 T, 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 T. Okay, so first question I ask myself, do I have P waves? Yes, I do. Do I have a P for every QRS? QRS for every P? Yes, I do. Do the P waves have the same morphology? Yes, they do. Is my PR interval within normal limits? No, it is not. So that is hard to see on the screen, but 1, 2, 3, 4, 5, 6, I don't know, 7. I can't really see too well on my screen. So maybe like 0.28 seconds or something. It's hard. Like I said, it's hard to see on my screen that I'm on here, but it's definitely over 0.20 seconds. And that's all. That's what matters. So then QRS is going to be narrow. R to R is going to be regular, and the rate is going to be somewhere between 60 to 100. So sinus rhythm with a first degree AV block. Why is it a first degree AV block? Because the PR interval is greater than 0.20 seconds. It is prolonged. Okay. Switch the slides here. All right. So this is where it gets a little tricky, guys. Second degree blocks, third degree blocks. People get confused a lot of times, okay? But if you pay attention, I'm going to give you a way to remember this, and you won't mess it up if you just follow the rules, okay? I'm going to give you some rules to live your life by as far as blocks go, and if you follow them, you'll be okay, all right? You just got to follow the rules. So let's talk about what's going on in a second degree type 1 or type 2 block. It doesn't matter which for right now. Let's just look at what we have on the screen with this little strip. So first question, do I have P waves? Yes, I do. That's weird, right? You're probably looking at that guy like, what is that doing there? That does not belong there. I would agree, it doesn't, but it is. So do I have P waves? Yes, I do. Do I have a P for every QRS and vice versa? So this P wave, does he have a QRS that goes with him? Yes, he does. That guy. Does this P wave have a QRS that goes with him? That guy. Does this P wave have a QRS that goes with him? No, he does not. There's no QRS here. Okay, does this P wave have a QRS? Yes, it does. That guy. Okay, so we don't have a P for every QRS. So that means that we have what we call a dropped beat. So the reason that we call this an AV block is because that electricity is getting blocked somewhere. So this P wave, remember what causes a P wave or creates a P wave? This is an atrial depolarization, probably from the SA node, I would assume. And that atrial depolarization goes downwards through the electrical conduction pathway. And then somewhere along the lines, probably in the AV junction somewhere, for whatever reason, this electricity got blocked from continuing downwards, because this electricity that comes from the SA node needs to get down to the ventricles to cause a ventricular depolarization and a QRS, okay? But it didn't. So there should be a QRS right here, but there's not, because the ventricles were waiting for the signal to come from the atrium to tell them to beat. But this P wave got blocked somewhere. It's like the phone call got dropped or something is kind of what's going on here, okay? So we would call that right there a dropped beat, all right? So that's how we know that this is a block. So if you was to come to me and say, how do you know something is an AV block? My answer to you would be, because you have non-conductive P waves. That's what I would tell you, okay? And that's hopefully what you would tell me as well. So this guy right here, did that P wave cause a QRS? Yes, it did, because it got to where it needed to go. Did this P wave cause a QRS? Yes, it did. Did this P wave cause a QRS? No, it did not. So I would say that that P wave right there is what we call a non-conductive P wave. And then this one, it caused a QRS right behind it. Okay, so non-conductive P waves are the hallmark of your AV blocks, okay? So you have second degree type 1 and a second degree type 2. So here is what I'm going to tell you, especially with blocks, guys. Do not memorize what blocks look like, because you will get yourself in trouble if you do that. Because a second degree type 2 has, you know, a 2 to 1, a 3 to 2, a 4 to 2, a 4 to 3, a 3 to 1. It has like so many different conduction patterns. You can't memorize them all, okay? And if you memorize one, you're going to think you know it, and then you get a different conduction pattern, and then you're like, I have no idea what I'm looking at, okay? So don't do that. Don't just memorize what they look like. Just follow the rules that I'm about to teach you, and you'll be okay, okay? So we're going to just draw some stuff out here, and we're going to talk about it, all right? And I'm going to do my best, because it's really difficult to draw on a screen that's at a 90-degree angle with a pen that's not really a pen. So we'll say there's a P wave there at the end. Okay. So now I'm going to draw one more. Okay. Let's look at what we got going on here. Ooh, I'm going to use my arrows. So what is that? That is a P wave. Does it have, well, let's systematic approach, sorry. Top rhythm. Do we have P waves? P wave, P wave, P wave, P wave, P wave, P wave, P wave. Yes, we do. Okay. Do I have a P for every QRS? Well, that P wave has a QRS. That P wave does not. That one does. That does not have a P, I'm sorry, that P wave does not have a QRS, but that one does. That's a P wave with no QRS. See where I'm going here? So let's back up, get rid of all that. Let me back up. I just want to do something here, just in case anybody's confused. Let's label everything. P wave, QRS, T, non-conductive P, P wave, QRS, T, non-conductive P, P wave, QRS, T, non-conductive P. You get the point, okay? All right, so do I have a P for, I'm sorry, do I have P waves? Yes, I do. Do I have a P for every QRS? No, I don't. The P waves have the same morphology. We'll say they do, okay? And in my PR intervals are the same. So we're just gonna say, for the sake of argument, that all my PR intervals are 0.16 seconds. 0.16 seconds. 0.16 seconds. All right, my QRS we're gonna say is narrow, and we'll just say that my R to R is regular in this particular case, okay? All right, so how do I know that it's a block? When you have non-conductive P waves, you have to figure out, why do I have non-conductive P waves? So if I have non-conductive P waves, first thing I'm gonna start looking at is my blocks. So I'm thinking to myself, I think this might be a block at this point, all right? We'll come back to that. I'm thinking it's a block, but we'll come back to that. Let's do the one on the bottom, because we're gonna do a similarity here in a second. So the one on the bottom, let's label everything. We got P wave, QRS, T, non-conductive P, non-conductive P, P wave, QRS, T, non-conductive P, non-conductive P, P wave, QRS, T, non-conductive P, non-conductive P, P wave, QRS, T. Okay, so kind of similar to the one above it. The only difference is the conduction pattern is a little bit different. So in the one above it, we had one non-conductive P wave for every QRS. But the one on the bottom, we have two non-conductive P waves for every QRS, okay? So the ratio is getting a little bit bigger. But at the end of the day, we all have non-conductive P waves. Now, one of the things that I'd like to point out here is we're going to say, for the sake of argument, as best as I could draw, that all of these PR intervals, when you do have a PR interval, you have to have a P, a QRS to have a PR interval, right? Let's just say they're all 0.16, just for the sake of argument. So what I'm going to tell you is that when you have non-conductive P waves and you always have the same exact PR interval every single time, every single time, it never fails to be whatever it is, it's going to be that over and over and over again. When you have that, when you have PR intervals that do not change, it's going to be a second degree type 2 block. So we're going to draw out like a little flow chart here in a second, but it's going to be a second degree type 2 block, okay? Let's look at this one. All right, so what do we got going on here? Let's label everything. P wave, QRS, T, P, QRS, T, P, QRS, T, P, non-conductive P, P, QRS, T, P, QRS, T, right? So that's what we got. So we have a non-conductive P wave. So that means we probably have a block. But let's go back to our systematic approach here. So we have P waves. Yes, we do. Do we have a P for every QRS? No, we don't, because that guy right there is a non-conductive P wave. So, all right, P waves, same morphology. I drew it as best as I could. We'll just say the P waves have the same morphology. And then the PR intervals. Now, I tried my best to emphasize this here, but this PR interval and this PR interval, right, are not the same, okay? So what are we seeing here? You have a PR interval that gets longer and longer, and then it drops a beat. Because when we drop a beat, we have a non-conductive P wave. And then it resets and it starts all over again, okay? So when you have a PR interval that gets longer and longer and then drops a beat, then goes back to normal. And then that PR interval gets longer and longer and drops a beat, goes back to normal. PR interval gets longer, longer, drops a beat, so on and so forth, right? That is going to be a second degree type 1 block, aka Movitz 1, aka Winky block. Okay. So if somebody asked you, well, what's the hallmark feature of a second degree type 1, you'd say that PR interval gets prolonged and gets more and more prolonged, and then it eventually drops a beat, and then it'll just follow that pattern for however long, forever, basically, right? So, okay, cool. So how do I tell the difference between second degree type 2 and a second degree type 1? All right, what I'm going to tell you, the easiest way to go about it is, let me go back to the screen share here. What I'm going to tell you is that when you have a second degree type 2 block, guys, your PR interval is never going to change. So if you have consistent PR intervals and you know it's a block, it's going to be a second degree type 2 block. Okay. Now, we got to talk about one more thing before we get to the next half of this little flowchart algorithm thing I got going on here. Oh, I broke it. Share screen. There we are. All right. So let's talk about a third degree block real quick. So a third degree block has what we call a complete AV disassociation. So for some reason, whatever, like that, the phone line has been completely cut between the top half of the electrical conduction circuit and the bottom half of the electrical conduction circuit. So like they're still both functioning, but they can't talk to one another. So the SA node is like, hey, we have no contact with the ventricles. I don't know what I'm supposed to do. I don't know what pattern I'm supposed to follow. I don't know how fast I'm supposed to go. So you know what? I'm just going to make some P waves, and I'm just going to throw them out there. So the ventricle is sitting here like, okay, well, we're not getting any input from the atriums. We're not getting any P waves. We have no idea when we're supposed to be. We don't know what we're supposed to do. So we're just going to take over, and we're just going to become our own pacemaker, and we're just going to go ahead and beat. We're going to do what we think we should do. So the SA node is making P waves, and the ventricles are making QRSs. But those P waves and those QRSs have nothing to do with one another, right? They're just completely random, okay? Because there is a complete AV disassociation between the top half and the bottom half of this electrical conduction circuit. Now, sometimes your QRSs can be wide, sometimes your QRSs will be narrow. It can be either or in a third degree block. So don't rely on just looking at one or the other. It can go either way. That being said, it will always be regular, because what did we say about ventricles when they are the pacemakers? We said that they are regular. So if you have something that looks like something looks like that, right? You're noticing you got a P wave here. I forgot to draw a T wave, sorry. A P wave here, a P wave here, a P wave here. That's supposed to be my T. P wave here, P wave here, T, P wave here. Their P waves on the QRSs are just, they're not really matching up. So let's just ask ourselves the questions. Do I have P waves? Yes, I do. Do the P's always have a QRS attached to them? No, they don't, because that guy and that guy, right? They don't have QRSs attached to them. So they're non-conductive P waves, as we would say. So how do I know it's a block? Well, I have non-conductive P waves, okay? And what's my QRS? Narrow, okay? And what's my R to R? Well, I did my best I could, but we're going to say for the sake of argument that this R to R is regular, all right? So if your R to R is regular, but you don't have a consistent PR interval, it's not the same, okay? Well, it can't be a second degree type 2, because if a second degree type 2, they always have consistent PR intervals. So I know it can't be a second degree type 2. So that tells me it's either going to be a second degree type 1 or a third degree. Well, how do I know the difference between the two of those things? Because a third degree block is always going to be a regular rhythm, regular R to R. Whereas a second degree type 1, yes, it's going to get longer drop 1, but because it drops 1, it's going to be an irregular rhythm with an irregular R to R interval, okay? So first question I'm going to ask myself is basically, do I have regular PR interval, right? And we're talking about blocks here. So I've already established that I have a block. I have non-conductive P waves. I'm trying to figure out what kind of block it is. If I have a regular PR interval, it's going to be a second degree type 2. All right. What if I don't have a regular PR interval? So I have regular R to R. Yes. Third degree. Irregular R to R. Second degree type 1. Okay. It's going to make more sense when we look at a couple of these guys. But I'm looking at the PR interval. If I have a regular PR interval in a in a block, let me back all the way up. If I have non-conductive P waves and I have a block, and I'm like, okay, what kind of block is this? Do I have a regular PR interval? Yes, I do. It's going to be a second degree type 2. If no, I don't, and it's a regular R to R, it's going to be a third degree block. If it's an irregular R to R and they get longer drop 1, it's going to be a second degree type 1. If you pretty much follow that, like, you'll be okay. All right. So let's just look at the PowerPoint and see what we got. All right. So second degree type 1. But let's see why. It's always about the why. P, QRST, P, QRST, non-conductive P, P, QRST, so on and so forth. So I have non-conductive P waves. I know I have some kind of block. Okay. Is my PR interval regular? Because remember, that's how I'm following this little flowchart algorithm thing. Is my PR interval regular? That one gets longer than that one. I have non-conductive, and then there's that, and this guy you would see gets prolonged as well. So are my PR intervals the same? No, they are not. It's subtle, but they're different, okay? So because they're not the same, it cannot be a second degree type 2. So I've ruled that out. Well, what's left? It can be either third degree or a second degree type 1. Okay, cool. I'm going to look at my R to R interval. Absolutely not the same, not regular, cannot be a third degree. I'm literally like doing a process of elimination thing with my blocks, right? I rule things out until I figure out what it is. So it's not a second degree type 2 because I do not have the same PR interval. It's not a third degree because I do not have a regular R to R. So the only thing that leaves me left with is a type 1, second degree type 1. And then once I figure that out, I kind of confirm things. I say, well, is this PR interval doing the getting longer drop, longer drop, right? Yes, it is. It's hard to see because it's not a very long strip, but that is what's happening. Okay, so that's how you work that little algorithm. If you just follow that, you'll be okay. So second degree type 2. Let's see what we got going on here. P wave, QRST. P wave, non-conductive P wave, P wave, QRST, non-conductive P wave, P wave, QRST, so on and so forth. Okay. So we know it's a block because we have non-conductive P waves. And well, what kind of block is it? Okay. I'm going to ask myself the question. Just remember, guys, if somebody says, well, this looks like it might be prolonged, how do I know it's not a first degree AV block? Okay. I see your point. Just remember, first degree AV blocks are not going to present with non-conductive P waves. Okay. So do I have P's? Yes, I do. Do the P waves all have QRSs for them? No, they don't. That means they're non-conductive. That means there's probably a block. Okay. Next, first question I ask myself in my flowchart algorithm for my blocks is, when I do have a PR interval here and here and here, is my PR interval the same? Yes, it is. Then it's a second degree type 2. Now, just something to point out, the second degree type 2 guys, depending on the conduction pattern, they can be regular or irregular. They can be either or. So the R to R interval thing on a second degree type 2 does not matter. It doesn't come into play because it can be one or the other. So it doesn't help me to differentiate between things if it can present every different kind of way. That doesn't help me, okay? So I'm looking for things that help me differentiate one thing from another, all right? In this case, the PR intervals help me differentiate. So just kind of recapping here. First thing I'm going to do, once I've established this as a block, I'm going to ask myself, do I have the same PR intervals? If I have the same PR intervals every single time, it's going to be a second degree type 2. If I don't have the same PR intervals, the next thing I'm going to do is I'm going to look to the regularity of the rhythm, the R to R interval. If it's the same, it's going to be a third degree block. If it's not the same, then I'm going to confirm with the longer drop on the P waves, which means it's going to be a second degree type 1. And that's how that works. Okay. If you follow that, you're going to be okay. So let's look at the next one here. So this is a little bit different variation. This kind of goes right back to what I was just talking about, what we were just talking about. So let's label things. P, QRS, T, P. Oh, geez, I'm losing my mind. Hold on. P, QRS. Really no T wave here. P wave, QRS. Really no T wave here. Non-conductive P, non-conductive P, P wave, QRS, so on and so forth. You get the point, okay? Now notice, this is not a regular rhythm by any stretch of the imagination, but I don't really care about that for right now, because the first question I'm gonna ask myself, because I know it's a block, and I know it's a block because it has non-conductive P waves, first question I'm gonna ask myself is, are my PR intervals, when I do have them, are they the same? Yes, they are. That means it's gonna be a second degree type 2. In this case, it just has a different conduction pattern, and this one ends up being irregular, whereas the other one ended up being regular. But as far as second degree type 2 goes, that doesn't really matter, okay? Third degree AV block. P wave, QRS, P wave, P wave, QRS, P wave, QRS. So we have P waves, but the P waves just are kind of all over the place. Like this looks normal, right? Like this PR interval looks pretty normal. Then I have a non-conductive one, and then this PR interval is like totally different than the other one. So that's like weird. And then I don't even have nothing here. So bizarre, right? So what we're seeing here is a complete disassociation between the atriums and the ventricles. The say no, the atriums are just pumping out P waves, and the QRSs are like, I have no idea what's happening. I'm just going to go ahead and do my own thing and make QRSs and live my life, right? So PR interval is not consistent. So if it's not consistent, it cannot be a second degree type 2. That means it has to be either a second degree type 1 or a third degree. So the next thing I follow in my little algorithm is, do I have a regular R to R interval? And if you really look at it, yes, you do. And because it's regular, It's going to be a 3rd degree AV block or a complete heart block. Okay. So that's pretty much how that algorithm works. All right. So if you follow that, you should be good. So let's just see. Let me got lines on the screen still. Let's kind of run through this PowerPoint real quick. See if there's anything that I didn't talk about that I want to talk about in this video. So we're going to talk about pacemaker rhythms in the next one. Cardioversion, WVW. Yeah, we're gonna talk about some of that stuff in the next video. So that pretty much wraps it up, guys, for what we wanted to talk about today. So in this lecture, in this video, and the previous video, they comprise the same lecture pretty much. So things that we've talked about are the different types of rhythms, what makes them a rhythm, why they're a rhythm. So sinus rhythms, atrial rhythms, junctional rhythms, ventricular rhythms. We talked about heart blocks, 2nd degree, 1 and 2 and 3rd degree. So we've talked about all of those things, talked about what makes a heart block, right? And what makes a sinus rhythm, atrial rhythm, junctional, ventricular, all of these things. So at this point, we should be able, hopefully, and listen, if you're like worried, like, hey, like, man, I'm still a little confused. Like, I get it, but I don't get it, right? That was always me in school. Like, oh, I get it. And then if someone's like, explain it to me, it's like, no, I don't get it, right? So like, I understand where if that's where you feel you are, I understand. What I will say is that once you start seeing things, because we are going to practice this, but before we get to the point we practice, we have to lay the foundation. Okay. So now that we've started to lay the foundation of stuff, we're going to be able to actually go and practice now, right? You know, you got to, it's like in a sport, you got to learn the plays first. And once you learn the plays, you can go out and run them on the field. Okay. So that's where we're at. For right now, guys, just work on learning the criteria and all of the things that we've talked about in these videos up to this point. Next video, we will talk about things that happen to rhythms. We're going to talk about premature atrial contractions, so PACs, PJCs, PVCs. We're going to talk about things called bigeminy and trigeminy, runs of VTAC. We're going to talk about something called Wolff-Parkinson-White syndrome, which is very, very, very important to recognize because it can be misinterpreted. And a lot of people will give, they will think it's, you know, like a SVT or something like that, and they'll give the wrong drug for it, which can have really detrimental consequences to the patient. So it's important to be able to identify WPW. So we're going to talk about that next time. And then at the end of next video, we are going to start actually looking at some rhythms. So that's where it gets a little bit more fun. And hopefully none of this is monotonous. I know it's difficult learning a subject like this, but you just got to keep plugging away at it. And once you start getting a little bit better at it, it starts to get a little bit more fun. That's all I can say. So until next time, guys, if you have any questions, of course, always please reach out. Thank you.